Okay, so now I'm going to present beginning. Hello, everyone. This is Deen from the Department of Family Medicine, and I'm here with Chad Terry, who is one of our really cool neuropsych fellows.
Not the fellow yet.
Not
I've
a
got the
fellow.
fellowship. I haven't started it
Got
yet.
it. He's a pre-fellow. He looks like a fellow, but he's
Because
a
I'm
pre-fellow.
old.
Oh, yeah, there you
It's
go.
a nice way of saying I'm old.
So he's here, and we're so happy he's here. And we're going to be talking about today for the next 40 minutes to an hour or so, a topic that many of you probably cringe and when you try to read or study. It's neuropsych medications. It's sort of that one of those black boxes of things in family medicine that we have to deal with. And Chad is so nice and agreeable to do this, and he's so good. He's got so many insights. I just thought immediately we had to do this.
Well, thank you, doctor.
So
I've got him fooled.
That being said, you guys also don't know we've already done this once and lost it. So you guys have no idea how much pain we're feeling right now. So that being said, Chad, before we get started, just tell us something about yourself. What do you like to do?
Well, actually, other than read medicine, which I really don't like to do that much anymore. See, I enjoy hockey. I like spending time with my kids. Like the great outdoors. Interested in space.
Nice.
Wanted to be an astronaut. Didn't quite make the cut.
Nice.
They don't let fat guys in space.
Oh, well, there's no gravity up there, so that shouldn't be a problem.
Yeah,
so
the problem is getting you up there.
Getting it, yeah, that's the right limiting step. Story of all of our lives. Well, it's good to have you here. We'll be skating through this topic, and we'll also be shooting kind of for the moon, and beyond with some of these topics. So first off, wanted to say when we're talking about these neuropsych medicines, we think about psychotic features. We think about patients who've got dementia features, who are having psychoses or those type of things. So we have a lot of uses for these things, whether they're schizophrenic, they have delirium, dementia, or even some of these stroke patients who have these features as well.
That's just it. Most of these medications, there's so much crossover you're going to see. You can use antipsychotics to actually treat anxiety, treat stress, treat behaviors. Again, you can also use antidepressants to do the same thing. You just have to be worried about how things play with one another and try to address the medication to the patient correctly.
Well, it sort of brings up a first little thing, and I think we talked about this last time, is whenever we're dealing, especially with elderly patients, and we'll kind of focus a little bit on that with the dementia, with the elderly demented patient, we can't just assume it's dementia. We have to think about other things too, whether it's post-stroke, mood disorders, abuse,
or simple delirium.
Or alcohol or other medication effects. So we just don't want to take for granted that, but we're going to say for the purposes of this exercise that we've thought through those things.
We're through the looking glass.
Yeah. And also, I think as we were talking about last time, that a lot of, boy, you're a good singer too, Chad. So a lot of these medications are really not FDA approved, for certain of these features, So we have to understand that we're using them because they have been shown to be effective in some of these patients, but we also have to have a high level of vigilance to sort of look over our own shoulders as well as our patients' shoulders to make sure they truly need them. So we'll launch right in the presentation, and the first slide here is just to point out where these medicines work, okay? So the nigrostriatal dopamine system kind of encompasses the caudate, the putamen. This is where we're working here in around the substantia nigra. So when we block these pathways, we're trying to block these pathways for the beneficial effects of these medications. And so because of this blockade, we also block these extrapyramidal effects, these paths as well. and we have these extrapyramidal symptoms that can occur
Yeah.
when we use these medicines.
Unfortunately, when you block something in the brain, you're blocking a lot of different portions in the brain, and you're going to get some reactions that you're not looking for.
Right, right. And so all of these medicines are working along these paths. We're trying to block DOPA effects. And again, this is just to show you that we have a lot of descending spinal pathways. It's called the extrapyramidal system. And so these are connections that are not really synapses in direct nucleus like you would see in a lower motor neuron. These are sort of speedy synapses that just sort of go from one side of the brain to the other, but these pathways are for coordination of head movements, eye movements, the trunk, the extremities. They help you maintain your posture and your overall muscle tone. So you can have, like we typically think of the corticospinal tract as directing a certain motor neuron, a lower motor neuron, but these extrapyramidal pathways are sort of a coordination pathway that is happening in the background that allows this overall big control of things. And that's these extrapyramidal pathways that we're looking for. Okay, so when we talk about extrapyramidal pathways, it's a major player here. And so basically, we're taking a look at the balance between dopamine and acetylcholine. And so the basal ganglia this is where all these paths are coalescing. And if we block DOPA, we're going to have an abundance of acetylcholine pathways. We're also going to block that filter that is running through the basal ganglia, and we're going to have a lot of motor issues.
Motor issues. And also, we should stress involuntary motor issues.
Involuntary motor issues. And that's what we think of with these extrapyramidal type of reactions. And so we have dystonic reactions like tongue spasms, neck, face, and back. We have Parkinsonian symptoms, tremor, shuffling gait, which is like a fenestrating gait, drooling, stoop posture, instability. That's like that Tim Conway guy.
Oh, yeah.
On the old Carol Burnett show, that shuffling guy.
I remember.
So his center of gravity is ahead of him, and he can't catch up with his own center of gravity. And then we've got akathisia, which are the repetitive motions, agitation.
Actually, another great way to describe that, too, is just intense restlessness. Patients won't know what's going on, but they know something's wrong, and they perceive it as anxiety. So that is actually probably one of the more, I'd say, ego-dystonic reactions that they can get right off the bat.
Interesting. And then we've got the dreaded tardive dyskinesia that can occur months to years later from use of these medications. And again, these are the lip smacking, worm-like tongue movements, fly catching. These just these spastic type of.
And again, you can get something very minor where people can't even pick it up, like slight grimacing occasionally, maybe a little bit of truncal rocking, to all the way to something that is completely debilitating, where the patient cannot function in this world.
Right. So that's just an overview of one of the big side effects of these kind of medicines we should be looking for when a patient is on antipsychotic medication. And of course, some of these side effects are due to acetylcholine, and we would treat those with anticholinergic medications if we happen to see that. And paradoxically, on the other hand, one of the things that always gets me is they also have anticholinergic side effects as well. And so, and it's not exclusive to just the antipsychotic class. You can have other, like the tricyclics can have anticholinergic side effects as well, so we're trying to look out for. So we've talked about the reactions, the extrapyramidal systems, but let's talk for a minute about the anticholinergic side effects that we should be looking for as well.
Okay. Actually, again, it's going to depend on your population where you're looking, okay? But especially in the elderly, you have to beware, okay? Because, again, that can also lead to, really easy precursor to delirium. But you are going to look for the urinary retention, probably number one. What's some sequelae of that? You're going to get a UTI. Um, Obviously, dizziness, falling, these just aren't good things. And, you don't have to be elderly for this to happen either. Just, it can make life unpleasant, just going through it drowsy, feeling like a zombie.
Right. It is every resident's on-call night in the hospital when you're dealing with anticholinergic side effects.
Actually, the first time we did this, that's what it, yeah.
Yeah, it's like, how many patients with urinary retention have you seen in the hospital? I can't even count. Or confused patients, or just having dry mouth, or things like that.
Yeah.
Or even in delirium itself from side effects of medicines. So again, we have to be on the lookout. We're protecting our elderly patients from these side effects as well. A lot of rich board questions too, so we have a little bit of interest there to pass the boards. So plug for that as well. So, when I was in medical school, they always used that over and over, and
They still use it.
they still use it.
We still use it.
Hot as a hair, blind as a bat, dry as a bone, red as a beet, mad as a hatter. And so these are all sympathetic effects. You could think of the fight or flight reaction. Mm-hmm. And so because we have inhibited the parasympathetic pathways, the sympathetic pathways take over. And so those are some things that you would see. And so I think a lot of times they use that just so in the pressure of the boards, people can sort of remember which one's sympathetic and which one's parasympathetic. But that's always been used around throughout teaching. So now we're coming to a table about some antipsychotics, and we've got Abilify up here, Haldol, we've got Zyprexa, Seroquel, Risperdal, and Geodon. And everybody listening, we're going to talk about these, but we're going to just leave the slide there for just a few minutes and talk about a few other things that we should probably touch on. So, again, using these antipsychotics for the delirium or demented patient when they have delirium, these are off-label use. There is an increased risk of death when antipsychotics are used in these patients with dementia-related psychosis. So we should be aware of that, and we should let our families know that the decision to go on one of these medicines really should be an informed decision, a shared decision.
Yeah, it's, again, I try not to use them. I don't know of any psychiatrist that wants to jump the gun with it. You do have to be very, very careful in the use of this. There's, and especially with the dementias, psychosis, there's absolutely nothing out there that we have specifically targets at. The closest we have would be Fanapt. It's an atypical antipsychotic, but it's directed towards Parkinsonian symptoms. Not dementia, but psychosis related to Parkinsonism. So it might be an adequate medication to try in this situation, but you want to make sure that you've eliminated all the organic concerns first, gone through your delirium protocol, light, nice spaces, reality orientation. Yeah, you want to use the meds as sparingly as possible in cases like that.
Right. And, the reason we first met, we were talking about a patient. I had a patient, an elderly patient living with the family, but just getting more and more paranoid, wandering around the house at night, not really wanting to take his medicines during the day, really hard to get anything in him. He had already seen a neurologist and they had prescribed something and didn't really want to take it to begin with. And you've got a family who's just a loving family but don't know what to do. Mm-hmm. Then they kind of come at you like, well, what do we do now? Yeah. And so you're kind of sort of backed into this decision to say, okay, well, we could try an antipsychotic because this sounds like psychosis. But again, we have to be aware and talk to our families about the use of these medicines.
Yeah, again, we have to be aware, and we have to make sure the families are aware, as long as they understand the risks too.
Right. And so some of the recommendations from the Choosing Wisely campaign, this was published just a few years ago, is don't prescribe this stuff for just behavioral and psychological symptoms of dementia without trying to assess the underlying cause, like you just said before. So we should try to make sure that there's no underlying, depression or something else going on. But again, the families are going to look at you and say, "Well, no, we can tell you that. Let's jump." So again, we're not supposed to use these as first choice. on that. So this should again be a thoughtful decision. So we should talk about the possible side effects, of the antipsychotic.
Is this the Abilify paper?
This is the Abilify paper.
Oh, okay. This kills me.
So, but we're going to talk about, we want to let the families know about anticholinergic side effects. We want to let the families know about extrapyramidal symptoms when they come in. So, again, there is an increased risk of mortality with use of these medicines. So, another thing is that from the Choosing Wisely campaign is that these medicines really should be stopped after a period of time if there's no evidence of any symptom
improvement. There's no improvement. You're wasting the med just introducing potentials for complications. No, you're on the wrong track then.
So, Chad, how long would you wait? How long before, once you start something and you're beginning to titrate up the dose, let's say of the Seroquel or whatever you're using, then you're going to see Uncle Joe back, or you're going to see the family member back. How long? It's been some time. He's no better. Are you starting to think about titrating up? Are you starting to think about quitting?
That's a terrible question. That's a terrible question.
That's why I'm here.
That's difficult to answer. It's a terrible question.
That's why I'm here.
Okay. It's actually going to, everything is going to depend on the patient and the medication. If I'm giving them Zyprexa, I expect to see something pretty darn soon. Especially depending on their symptoms. If they're having a lot of positive symptoms of psychosis, a lot of hallucinations, a lot of acting out, you want something effective like the Zyprexa, and those behaviors should, be significantly reduced in, a matter of just a couple days. Whereas, if you're going after somebody with, something like Seroquel, where it's a slower titration, doesn't work as well for the positive symptoms, it would definitely take a little bit longer.
So you're saying Zyprexa has a quicker onset of activity versus that? Yeah.
But then long-term use, Zyprexa just isn't used long-term because, well, it is used long-term. But I'm saying I try not to because you're going to introduce a lot of metabolic side effects eventually. It's just going to happen. You're going to increase the blood sugar. People are going to put on weight. In almost all cases, just eventually it's going to happen. Interesting.
So, believe me, folks, we're going to get into each one of these medicines as we go through. But just to set the topic up a little bit more, interesting, about 15 to 75%. That's a nice, accurate number there.
15 to 75.
Exactly. Of people with dementia are going to have, catch this, some type of delusional misidentification, hallucinations, usually visual, wandering, agitation, aggression, or other psychotic behaviors. So when you're talking dementia patients, it's almost you're talking some type of psychosis at the same time, aren't you?
Actually, I'm going to break down. Those statistics finally made sense to me. The 16 to 75%. Think about it. Back when you're walking onto the ICU or something, you never know the amount of people were going to be that day. So they just put down the numbers every day of the week. Today we got 16%. Today we got 32. Today we got 75. Okay, that makes sense. Okay,
I'm so glad.
But actually, and the easy way, and I believe probably the correct way to look at like dementia is like a psychosis that doesn't get better if you throw meds at it. Best thing to do for that is behavioral modifications. Reality orientation, the stuff that's hard work and takes a long time. Obviously, medications to make the patient, comfortable, but you're not going to do anything like, obviously, chemical restraints is not a term we use or even think that way anymore, and I don't believe that we have since the 1960s.
Right.
But you do want to give them something to make them feel better, more confident for their safety.
Interesting. Like the true astronaut you are, you have plotted the trajectory here in the conversation. Is that these symptoms that we just talked about are really significant, that they contribute to caregiver burnout, family burnout from caring about this stuff, and that reassurance to the family is almost just as important as any other part of our treatment, because they've got to know, because they will come in with a whole lot of guilt that they just can't handle grandma any longer. And so family and caregiver burnout is crucial to this. But just as you were talking about, that the non-pharmacological interventions are really just as crucial. And so we have, establishing daily routines, toileting, eating, medication administration, socialization attempts, the structure involving all of those things are really, really important, as well as the physical barriers to prevent wandering and those type of things. So without, behaviors that can be corrected, certainly life will be better, but if they're not, then we're getting into the other choices that we have to make with medications.
Actually, just on the flip side too, I want to back up for a second, like you said about families. You got to they're a unit too. They're being severely impacted. If I get a chance to meet with them, I always try to do a little evaluation because, I've seen, and I'm sure you've seen this too. Elder care, it can destroy families, can lead to suicide.
Oh, for sure.
And I just try to find out what's going on, and just see if you can offer some help or some direction to the family too.
Right. My rule over the last period of time I practiced is that you really need about 3 people to take care of one person for the long term. One person to take care, one person to run errands, and one person to get some sleep. And it's like if you don't have that, you're 2 people. It's tough, but they can do it if they've had experience. But one person is tough, really tough. So I see this a lot with the elderly wife who's got a demented husband, or the elderly husband who's trying to take care of his demented wife. It's tough because you only have that one person trying to manage that. So let me throw a couple of we didn't do this last time. I wanted to do something a little different this time too, is to throw out a couple of these behavioral techniques and see what success you've had with them. The first one is just the basic taking care of thirst, hunger, pain, toileting, nausea, sleep, those type of things. Those are the basics. But then you get into some of these other things like music therapy, aromatherapy, light therapy, massage therapy. Have you had a lot of patients deal with those type of kind of?
I'll be completely honest. Massage therapy, no. Aromatherapy, usually they're just subjected to bad smells. I'll be completely honest with you. There's not too many options for that. And the music therapy, you know what? I have seen a lot of benefit out of that. You put on something cool, something calming, and it's just a universal. People can relax.
How about the cognitive stimulation type of things, like task-oriented behaviors? Have you done a lot with that?
Actually, yes, we get a lot of benefit out of that. The adult coloring books, mandalas or whatever they're called. Actually, I had a patient. The poor guy really didn't know where he was. He had no real connection to the world anymore. His Alzheimer's was really far advanced, but he could remember how to make models. And that guy just made some of the most amazing models. Interesting.
Well, that kind of goes back to even reminiscence therapy. I had a patient recently in the last couple of weeks. He was an elderly fella. I was at Books A Million, and I just, happened to pick up a big book of America. It was on sale, one of those $9 specials that looks like it should be sold for a lot more money than that. And so I said, I'll just pick one up for him, and I gave it to him. And he looks at it. He looks at the pictures at night with his wife, and it's like he can remember pictures, and it gives them something to do, and they use that to transition to going to bed. But I thought I don't have a lot of experience with it, but it just kind of came like a common sense type of thing, something we could do for those patients. But I suppose in the land of videos, looking at family videos and things like that might be an interesting pastime too.
Family videos, I loved how you did with the America book. Keep it broad. We try to, when we get too specific at times, it's actually been very disruptive for the patients because they realize they're missing a big part of their life.
Oh, yeah, interesting stuff.
So, yeah, but like you said, keeping it broad.
Keeping it broad.
Yeah, that's fantastic.
Good advice. Thanks, Chad.
No problem.
Yeah. So, let's see. So, I would like to now maybe we'll touch base on some of these different classes here. So, we've got a table here. We were looking at Abilify, like right on the bat. Let's now everybody's. If you're still awake out there, if you've been with us now, you probably know that you've been looking at this same slide for about 15 minutes. And so now we're actually going to use this slide. We did this because I don't have any other slides except for the ones I'm going to show you. So why don't we take a look, and I think it serves a purpose. Like, there's so many of these medicines, and you're picking either you have your favorites or the ones you're comfortable using, but we really do want to be aware that they have different effects, that we want to use them, and that may help us make our decisions. So let's just pick on Abilify for just a minute and kind of look at that. What do you think?
I love Abilify. It's a fantastic medication. First weight neutral medication in its class. Low side effect profile. People just seem to get better. It's a great adjunct for depression. Even if you have to treat bipolar disorder with one medication, it usually works well. I cannot sing the praises of Abilify enough.
Wow. And that's come from, he's not even, I'm looking at him right here, he's not even thinking about that.
No, because it hurts, because I know where you're going. You found some information that I was not privy to.
No. So let's take a look at just Abilify for just a minute as a group. Look at this. Doesn't really have a lot of anticholinergic effects.
Don't expect it.
So if we've got somebody with a lot of urinary retention or a big prostate or something like that, we're going to like Abilify. In the extrapyramidal symptoms, we like that.
Yeah, it doesn't seem to induce any EPS in hardly anyone. It's very rare when it does.
Right. Now, can we use this? Is this one of our medicines that we can use in the Parkinsonian demented patient? Is this one?
You can, but it's not my go-to.
It's not your go-to?
No. Parkinsonian demented, I definitely go with Fanapt first.
Okay. So, but it does have a low extrapyramidal symptom profile here. Doesn't really cause a lot of hyperprolactinemia, which is nice. And they all have a little bit of a risk for neuroleptic malignant syndrome.
Well, just about anything where frankly, any psychotropic does. Antidepressants, marijuana, St. John's wort.
It's one of those that you see, but I've only rarely seen it in my career. Only rarely.
Well, not full-blown. NMS I've only seen a couple times myself, but I've seen serotonin syndrome quite a bit. Yeah. And actually we're seeing quite a bit of it off of marijuana now. Interesting.
So they all have a little bit of prolonged QT.
All antipsychotics affect the QT, except for Vraylar.
Okay, except for Vraylar.
Yeah, everything else does.
And as far as sedation goes, this is probably not going to be one of your picks if Grandpa is not wanting to go to bed, right? It's not as sedating as Seroquel is.
No, it's not as sedating actually. This is it's actually a positive. Most people can take Abilify and they don't feel like zombies. They can walk around. They can function. They feel great. Abilify isn't my first choice, and I can't think of anybody whose first choice it is for the positive symptoms of psychosis. It'll treat them, but it's not what you would normally want to give somebody to help stabilize them initially.
When you say positive symptoms of psychosis, could you explain that for a minute?
I'm talking about the hallucinations, both auditory, visual, some cases tactile, a lot of bizarre beliefs, the disorganized thinking, wild behaviors.
Right. So again, this is a good entry-level antipsychotic that really doesn't cause a lot of trouble and maybe can help with some of that psychosis some of that.
It seems to play well with just about everything.
And then that might be an option as we talk about some of our other medications for our sedating medications. We can combine this with other things.
Also got to point out, it's one of the few antipsychotics that comes in an effective, long-acting injectable formulation. And if you use Abilify, Aristata, 1066 milligrams, you can extend the dosage out to 2 months. So that makes, when you have to tell people that only have to take their medications 6 times a year, It makes things easier.
Wow. Wow. I don't even think we talked about that last time. So it's a plus
Yeah,
for
it's
this.
a plus.
Yeah. So that's really, really good. So let's compare that to haloperidol here. Haldol, seems like that's been around for a while, and
It's been around for a while. It's effective. It's cheap. Um, but if you're a young, muscle African American male, uh, you should not get it. Because if you're young, it doesn't work. Well, it works just as well. But we're talking about inducing like EPS and and worrying about heading on to NMS or something worse. Same with young African American that they African Americans just don't do as well with it, meaning more likely to develop side effects.
right.
Males, we don't do as well with it, just more likely to develop side effects. And
Right.
yeah, so it's just definitely, you ER guys out there, don't do it, okay? Don't
Right.
give Haldol in the ER to young African American males, okay?
Right. Well, we see a lot of we see more postural hypotension too.
Yeah.
It is more sedating. That's probably why people would be using it in the hospital. When I was training, that was used a lot,
Yeah.
for the nighttime sedation kind of stuff.
Yeah, it works. It works. It works quick. It works well for when people need immediate treatment. But in the past, again, it was they would call it chemical restraints, that's thinking about it backwards. If you're thinking about you're using to restrain the patient instead of rapid neuroleptization for the patient's safety. If they're fighting and they're at risk of being tied down or restrained, you're talking about there's a lot of trauma that they go through getting in that. We're not even talking about the rhabdomyolysis, which is very common. Rhabdomyolysis, okay, whatever. Rhabdo. Yeah, there's a lot of concerns for patient safety there. So yeah, if you need to make sure that they don't get injured or risk doing that to themselves, yeah, then that would be a much better choice than Abilify.
Got it. So in that scenario, your best, and Haldol comes in a liquid form too, doesn't it?
Yes, sir.
Yeah. So that might be an option for people who are not able to swallow pills.
Yeah, it's you can go ahead. You can take it orally. You can take it IM, and it also comes in a long-acting injectable, up to 4 weeks. But it's oil based, so it's very painful to take to actually get the injection. And but it is effective, but you still have the side effects of Haldol.
Right. Okay, so let's switch over to Zyprexa. That's a little bit newer medicine.
It's an
atypical, and it seems to have a little bit more sedation, but it does not. It seems to be pretty good as far as the anticholinergic and extrapyramidal side effect risk.
Yeah, Zyprexa is a great medication. I mean, it has just as much, if not more efficacy than Haldol for that immediate taking care of the psychosis. I've actually seen it almost work miracles on people complaining of anxiety, depression, things that you wouldn't normally associate with an antipsychotic. But if you can go ahead and get them on a dosing where I've done it, monitor them for like a month, and then transition them to straight antidepressant, it's been fantastic. It serves a lot of different roles, much like Abilify. Think about it really as an Abilify that is just far more sedating and more effective for the positive symptoms. But again, long-term use, I'm not a huge fan of it because of those metabolic symptoms that are going to happen.
Right. And metabolic symptoms, you're talking about dyslipidemias,
yes sir,
and the risk of diabetes and weight gain.
Yep.
So you might not be a very popular doc, if the patient starts gaining weight and catching diabetes.
Yeah.
So, and I was just looking at this table here. They did a bunch of meta-analysis published a few years ago, and they showed that the Abilify consistently resulted in reductions in the positive behavioral aspects of the dementia. So on one hand, we've got Abilify over here, because I know you like Abilify so much. I wanted to say something really good about that.
I appreciate that.
So, and then they kind of looped in Zyprexa, Seroquel, and Risperdal. So here's Zyprexa, Seroquel, Risperdal right here, and they were sort of they were effective, but a little less consistently effective than the Abilify was in some of those. So I'm kind of trying to get my mind on these three because they're all sort of together as a group as well. So let's take a look. We talked a lot about Seroquel over the last few weeks. You know, when we were talking about the patients that need to be sedated, and so now we are pulling out. You know, at least Zyprexa and Seroquel have sedation here. So what do you think about this as a medicine?
The Seroquel, you're getting different results at different doses. Low doses, people take it just merely for sleep, 25 to about 100 milligrams sometimes. You know, when you get up to 200, 300 milligrams, you're getting, you know, mood effect. Where you get, you know, 300, 400, you start hitting that antipsychotic range. There's several problems with Seroquel. Well, there's several benefits too. One of the difficult, it only comes in tablet form. Whereas, you know, if somebody needs, you know, to get an injection, needs it now, you'd be going with Zyprexa. You wouldn't be going with Seroquel. On the plus side, actually, out of all these medications and everything other than Vraylar, Seroquel is going to interfere with your QT interval the least.
Right.
So it's going to be safest for, you know, a cardiac patient.
For cardiac, I think they had the least effect on the. You remember when we started saying that all of these medicines had increased on mortality rates? That at least from the data I was looking at, that the Seroquel had the least effect on that increased mortality rate.
That makes sense.
So it's a safe medicine if you're dealing with a heart patient or somebody like that, or safer medicine.
Yeah, that's yeah.
Okay.
Then again, it's, you know, people enjoy Seroquel when they take it generally. I can't say that for, say, Zyprexa. Some people, you'll have a lot more people say, I just don't like this, I don't feel good.
Why don't they like Zyprexa as much as Seroquel? Why do they seem to enjoy it?
Seroquel, actually everybody who takes it for Seroquel, they seem to enjoy it. It helps them sleep. They like that, and they really don't feel any lingering effects. Zyprexa, you'll get some people that don't like the way it makes them feel. That's how they explain it. Not as many as say Haldol. Haldol, you get a significant, I don't like this.
Right, so since we're talking about sleep, and a lot of residents out there are going to be dealing with patients who have dementia, patients who are restless at night, that seems to, I think, make doctors nervous the most.
Very
You've
much
got
so.
a patient who won't sleep, the family doesn't sleep, and everybody's really coming to you, and you got to prescribe something pretty quick to settle everything down. When you prescribe Seroquel, how do you generally tell them to take it? Are you telling them to take it an hour before bedtime? Are you trying to slip a little in them at dinner time? Or how fast is this stuff? Are you expecting this stuff to kick in so that Granny will finally lay down and go to sleep?
That is a great question. Thank you.
You
Because
know,
that's easy.
Well, that was a mistake, I guess. I usually come up with the bad questions, but...
No, the bad questions are hard to answer. This one's easy. I like
right,
this one.
Bring it.
What I tell everybody, any sleep medication across the board, I say take it 30 minutes before you go to bed. And then I ask them to figure out for themselves if they need to move forward or move back with it. As I do, and I make them take notes so they can bring it in, a sleep diary or something. I want to know how long they took it before they went to bed. And I'm also a big believer in having a little sleep ritual, we'll call it.
Okay.
An hour or two before you go to bed, you turn off the screens. You got these phones. You put them down. You don't look at it unless you're using it for your alarm. You know, it's just not there. Actually, you know, this is hardcore pharmacology here, folks.
Bring it.
Celestial Seasonings Sleepy Time Tea, the one with the little bear on the box.
Right. I've seen it.
Yeah, I swear by that stuff.
Okay.
Absolutely nothing in it that'll make you sleepy, but when you start to associate it with sleep, you get your little mental thing. You sit down with that. If I don't have my tea that night, I'm not going to sleep.
Really?
Yeah.
Interesting stuff.
And my sleep was terrible. Absolutely terrible. So I went ahead and started practicing what I preach.
A little ritual?
Yeah.
Great. Well, another offshoot question would be, is if they can't really, how do you, so if you move it up closer to bedtime, you're expecting it to kick in closer to when they need to go to sleep, or if you're backing it up, are you looking at whether or not they're going to be staying up? You know, you would move it closer to bedtime. That's kind of what you're thinking.
What I want to find is because I need the feedback from them to see what's going on. I've had patients tell me, look, I can't take it like that because I couldn't stay awake to brush my teeth. Like, okay, that's fine. But go ahead, lay in bed, pop the pill, turn off the nightstand light, roll over, go to sleep. Great. That's what works for you. Then I've got other people who's like, okay, I took it, and then I got up, made myself some coffee, went around, watched some Quincy on TV.
Oh, Quincy will put you down.
Yeah,
Yeah.
as the kids are likely to do.
And in general, Seroquel and maybe a little Zyprexa too, are they going to leave you drowsy in the morning if you, or as compared to like Trazodone or something other?
It's a coin flip.
Coin flip, got
Yeah,
it. Okay.
And if you, again, like most everything else, if you jack the dose, it gets up there, you're more likely to get up.
Have that. Okay, so we've talked a little bit about Seroquel and the usefulness of it in terms of helping people be drowsy, and also the safety compared, to the cardiovascular risk that all of these medications would have. How about risperidol? This is a medicine that's been around a long time. As a matter of fact, for me, we used this a lot when I was training early, even before Seroquel. And so, but I don't think it's as favorable as Seroquel now for helping people be drowsy. What do you think?
I think, if I recall correctly, just sitting here, I need to go and review it, but I believe risperidol is just a slightly modified Haldol molecule. Again, don't quote me, folks, and I will be looking that up after this. But it came out in the day like, ooh, great! One of the first atypicals, cool. We don't have all those nasty effects you got with Haldol, that you got with Prolixin, that you got with Thorazine. We work well, we work strong. We're safe.
Right.
That's not entirely the case.
Right.
It is effective. But prolactin, that's a real thing. That happens with all of my risperidol patients. And folks, let me tell you something right now. Do not get a prolactin level if you're giving somebody risperidol, okay? Because guess what? You're going to just mess them up, because you're going to have to change that therapy. People who, I have to leave my patients on it who have bought into risperidol. They love it. They think it's the only thing keeping them out of the hospital. Please don't start anybody on it, okay? It does work, but it comes with a lot of nasty stuff down the road, okay?
Right. So doesn't risperidol come in a liquid form too?
Yes, it does.
Okay.
Actually, I think that's one of the main reasons why, especially like for autism, it's been one of the most studied medications, and it's the only one that's actually recommended right now.
Really?
Yeah.
Interesting.
So
it's probably recommended because it's been studied the longest.
That's why.
You think?
Yeah. I'm sure. I know for a fact other child psychiatrists are using other medications off label, but yeah, risperidol is the only one with recommendations.
Wow. Well, it comes to Geodon over here, and Geodon was the most ineffective of all these, or at least I think in terms of some of the studies I was reading.
That's what I'd expect.
It's not. It has a pretty low side effect profile, though. I mean, that's good.
Oh, no.
But
The thing is, I know psychiatrists who swear by it. They love it. They think it is, like I talk about Abilify. Right. They think it's fantastic medication, don't see a downside. Me, personally, I think it's difficult to dose. I don't see it as being particularly effective. Like I said, I still know, I actually know a bunch of ER docs now are using Geodon instead of Haldol. And they claim to be getting better results. Again, that's just anecdotal, and I haven't seen it.
Interesting. So that's just a quick breakdown of some of these selected antipsychotics here. Again, all of them have greater risk of death. It looks like Geodon, if we see that on the boards, that's going to be probably the one that we would label as the least effective.
Actually, I just want to go ahead and say, if you are in the ER though, Seroquel would be your last choice out of everything on this board, because Seroquel and then Abilify, like ER work, because it's just not going to, help people, quickly.
Quickly.
Yeah.
So it's going to take a little bit with Abilify, and the Seroquel is going to take a little bit more titration time.
Yeah. There is an IM formulation of Abilify, but it's just not as good of the option as the others.
Right. Zyprexa is going to kick in a little bit quicker.
Fantastic choice.
Interesting. And again, we said Seroquel increased the mortality rate the least of these events.
The safest.
The safest. So let's see. So now, when we talk about monitoring these medicines, once we get our patient on these medicines, let's see if we can go to a new slide. So
You've been waiting to do this.
we've been just to show you guys, we have gotten our money's worth out of that last slide. So now we're going to look about once we have our patient on these medicines, we are going to look at the adverse side effects associated with them. So anticholinergics, blurred vision, confusion, constipation, dry mouth, urinary retention, we talked about that. Extrapyramidals, muscle spasms, pseudo-Parkinson's, bradykinesia, rigidity, tremors, and restlessness. We talked about those. The hyperprolactinemia, that you were mentioning there.
Yeah, Risperdal it's just going to happen.
Acne, galactorrhea, gynecomastia, hirsutism, reduced bone density. Are you checking bone density tests on your Risperdal patients? Are you checking for that, or do we worry about that? I mean, it seems like the bone density.
No. We do.
You do.
I don't check for it, but I tell them. I put it on you guys.
That's what we're here for.
I put in referrals directly electronically. My outpatient clinic allows me to do this because most of our patients I work in a community mental health setting, so we have actual physicians who are monitoring their medical concerns along with us. So it makes it easy. Most of you folks aren't going to be this fortunate.
Right. So again, those are things for all of us to be looking for. Again,
Actually, one of the things too I'd like to mention, especially like in elderly, demented patients, they're not going to be able to tell you a lot of times about the anticholinergic effects. You just have to be on the lookout for it. Right.
Now, if you have any anticholinergic side effects like this, you either have to make a decision to treat, maybe with like Benadryl or something like that, to reduce some of that, or you've got to make the decision to switch medications. Yeah. Totally. What is your approach there? Do you use a lot of Benadryl for these effects?
Actually, for the most part, we try to stay away, especially in the elderly. But I mean, when it comes up, you need to. Benadryl is a great choice. It's an amazing medication. Usually, though, we'll go to benzotropine, cogentin. It's also an acetylcholinesterase inhibitor, and but obviously. Always try to take off the offending agent. See what you can replace it with. More gentle. I'm a huge non-fan of polypharmacy, especially in the elderly. So yeah, try to keep it simple. Try to keep it sweet. But you want to address that. Pull off the offending agent and see how little medication you can get by with.
Right. Now, in some of these elderly patients with low GFRs, they've got chronic kidney disease at the same time. Do you usually start maybe at half the adult dose on all these patients, or how do you?
Actually,
you're going to go a little bit.
You do it on a per patient basis.
Per patient, so you're going to get a lot more bang for the buck in the chronic kidney patient.
Oh yeah.
So you don't need as much as you think you might.
Yeah. There's no little chart you can come out and just go. Just a flat dose for everybody. You gotta keep thinking about this.
Now, as far as these medicines go, how long would you wait to titrate up dosages? Do you bring your patients back in 4 weeks? Do you have them call, or when you start something when you start somebody on one of these antipsychotics? Well, how's your follow up?
Again, hard question.
That's why I'm here. That's what I what I do.
Okay. Easy part of it depends on the patient, and it depends on the medication. It depends on the situation. Depends on what they're going through. If it's something like they're having anxiety attacks, and we've started them on, say, a small dose of Zyprexa and Buspar, I'll try to see them back, in a week. I know Buspar, you should take 2 weeks before you go ahead and advance it, but I want to make sure that they're doing okay.
Great.
If it's a patient been stable for 20 years, and we're taking the Abilify from 15 milligrams down to 10 per day, a month will be fine.
Got it. So here's a recommendation on duration of treatment. They looked at all these trials, about 9 different trials about symptoms with dementia and discontinuing of the antipsychotics. So after one of their conclusions was is if symptoms don't improve after a 4-week trial of the antipsychotic medications, the medication should be discontinued.
Mm-hmm.
So now at that point you're thinking, should I discontinue this or should I just increase the dose?
I'll be honest with you. I really can't think of too many situations where if you got anything acute, you would wait 4 weeks. Obviously, if you're working in a senior care facility or something, and you only
Right.
come through once a month, that's your only option. But if Seroquel could take a little while, it should not take 4 weeks. I can't see going more than 2 weeks with it, and not just going, this isn't working.
Got it.
Some of the other agents, like say Risperdal, Zyprexa, Invega, if it's not working after a week, I'd say it's the wrong treatment.
Interesting. Okay. So again, just looking at side effects, it goes back sort of the burden is on the doctors and the family to look for these signs, to look for these effects, to either make decisions whether we should titrate down the dose or change the medication. Have you had a lot of success or failure or insights with if you stop a certain antipsychotic and start them on another? Do you get a little bit better response if you're changing between one family or one medicine or another? Or
I found with if you have the ability, especially with psychiatric meds, always best to cross titrate. It's just sometimes jarring just to go from one to the other. More often than not, it'll be jarring to go.
So
from one
as
to the
you
other.
decrease one, you would be
Yeah.
adding another and cross titrating up.
Yeah.
That would be how you would do it, rather than bring them down and
Yeah.
then start them from the
Yeah,
beginning dose up. Yeah, that's a
Exactly.
really important point. I'm glad we touched on that.
No,
Yeah.
no problem. Well, that's just it. I think we actually have books on that. You guys don't.
Yeah, it's something that the average family doctor, they're lucky to be able to try the medicine, to feel like they've got confidence to do it, and then they'll titrate up a little bit, and if they get a better effect, great. But if they're running into side effects, it's like, what do you do? What is the side effect? Or sometimes it's not really on their radar screen to ask about the side effects because grandma is really being taken care of by grandpa, and grandpa doesn't look for the side effects either, and your office is really busy. So I think it's important for us to keep it on our radar, but if we have to titrate down or switch categories, that's really helpful for us to know that we could cross-titrate up with another one.
Matter of fact, actually half the time the patient will come in, they'll discontinue the medication on their own. And that's when you know you just have to add another one.
It back.
Yeah, other than that, cross-titrate.
Okay, so I think we might have one more slide. Let's see. So these are some recommendations for monitoring for the long-term use of these antipsychotics, okay? And so a lot of these antipsychotics we're supposed to check out for things like cataracts, slit lamp exam at the treatment initiation and every 6 months if a patient is getting Seroquel.
I told you, I saw that question, I had it on step 1. Have not seen it since, have not thought about it since. I am not aware of any patient, literally thousands of patients that I've seen taking Seroquel, not aware of a single one ever getting a slit lab examination.
Interesting.
And I think I feel that I've been contributing to that.
So
far I haven't blinded anybody.
So it's something for us to think about, for these patients and probably for family doctors even more than anybody, for checking lipid panels, checking fasting plasma glucose at the treatment initiation. Maybe they're saying at 12 weeks, then annual if getting these atypical antipsychotics. And just as an aside, where does the word atypical come from the antipsychotic family? Why do they call some why do they call them typical versus atypical antipsychotics?
Dr. Deen, that is a great question. Because literally, they had a group of antipsychotics, and they came out. The first atypical was Clozaril, and they said, well, it doesn't work like these others do. So I guess since they're the ones we have, they're the typicals. This is the atypical.
Isn't it amazing how we just worship these names, like, oh, it must be so atypical, like it's the direct Billy Rubin and the indirect. Oh, the big mystery there. Okay, so the atypicals, we're going to be measuring waist circumference, BMI, we're doing that, and then nutritional counseling. So we're checking really for weight gain, I
Yes,
would
sir.
suppose, and for hyperlipidemia.
And everything that comes with it.
Extrapyramidal, we talked about that. We've really talked about consistently through the whole lecture here.
I know, especially like family guys, you guys are so slammed, but you can actually do just a really quick, brief mini Ames exam. Just go through, have a patient stick out their arms, full length, stick out their tongue, and then run through the sequence of where they touch each finger to their thumb, back and forth, make sure there's no physical. That would actually be sufficient for your knees to establish if you got something to worry about. And then just, watch their posture. Are they rocking? Are they doing a lot of odd toe tapping? It doesn't take much extra time, but if you can catch something, you can literally, you can save somebody.
That's great. That's great. And for those of you who are not here during this taping, it was really nice to watch Chad, demo that. His fingers were out. It was really. I wish we had a film of it. It was just really helpful.
But I got the face for radio, so
yeah.
You're lucky you don't have the film.
So let's see. So we talked about that. Now, what I'm going to do is I wanted to sort of to make this into two parts. So I'm going to end this here. We're going to stop this, and then depending on our time, we're going to flip up and do a second part to this, and this is using some of these other medicines, these other neuropsych medicines, such as for patients who you're trying to find good medicines for anxiety, a good medicine for sleep. We get a lot of that. We get a lot of these patients who are on benzodiazepines, and we're trying to find better medications.
Mm-hmm.
So last time we talked about it. So I think what I'm going to do is I'm going to take a second and flip us over to a different screen. So everybody hold on.
All right, I know you guys can't appreciate this, but he's got a slick little system here, okay?
Let's see here.